So I'm going to say a little bit about hip arthroscopy. Well, first of all, what is hip arthroscopy? I think most of us know what knee arthroscopy is. I'm sure you may have had a knee arthroscopy yourself. I'm sure you've had friends or relatives who had a knee arthroscopy. And basically, for want of a better description, it's part of putting a telescope, a surgical telescope into the knee for keyhole surgery. And really, that's what hip arthroscopy is for the hip. But there's some very important differences. The knee joint is quite a superficial joint in terms of being obviously very easily accessed from the skin, and it's a fairly quick operation. The hip arthroscopy is a lot more taxing because of how well the hip is covered. But in principle, a hip arthroscopy allows an arthroscope to be put into the hip joint and images displayed on the screen. So hip arthroscopy is a visual inspection of the hip joint done through an arthroscope, inspecting the articular surfaces, the acetabulum, the femoral head and the surrounding structures. But the other part of hip arthroscopy is to look at the extra-articular or the para-articular areas of the hip, the anterior and posterior areas as well, to look for impingement problems, and also look for other pathologies within the hip joint, loose bodies, labral tears, and other pathologies that may be suspected by clinical diagnosis or from a variety of MRI scans or other techniques. So why is hip arthroscopy carried out? Well, that's a very good question, and certainly 20 years ago hip arthroscopy wasn't a common procedure, but it was pioneered in this country by Richard Villa, a well-known arthroscopic surgeon, mainly using it for diagnostic purposes at that time, and at that time didn't really have much to offer it in the form of treatment. So arthroscopy is now used quite differently. We have a better understanding of the certain pathologies that can affect the hip joint, particularly over the last 10 years, and certainly over the last 5 years. We're recognising different pathologies that can affect the hip, which are amenable to keyhole surgery. Now, there are some obvious conditions such as a loose body in the hip, a piece of material that could come from the femoral head of the acetabulum that can be quite simply removed. When I say quite simply, that's not always the case. You've got a small pebble in a joint. It's not always easy to do, but they can be removed without resorting to open surgery. But more recently, we've recognised other pathologies. The labrum or the fibrous ring around the hip joint can be torn. You can get lesions of the articular surface, so-called carpet lesions, and other lesions caused by impingement problems. And the impingement problems themselves. The impingement is when you get abnormal anatomy. There are basically three types: cam impingement, pincer impingement and combined impingement. And it's the combined impingement which actually is quite common. The cam impingement is frequently associated with a bump on the femoral neck, and in flexion the hip actually is levered slightly out of joint. You have a lack of roundness of the femoral head. You get loading of the periphery of the hip joint. You quite often get a labral tear. The labrum is an important structure because it helps to anchor down the articular cartilage. The articular cartilage loses adherence to the subchondral bone. It lifts up initially as a carpet lesion, and you start a degenerative process. With pincer impingement, the pathology is on the acetabular side rather than the femoral side, and there's an over-prominence of the acetabular rim. So when the hip moves into flexion, it's the sharp edge of the acetabulum which levers on the femoral head and neck, causing an incongruity of the joint, causing similar problems already described. And not uncommonly, you get a combination of the two pathologies. So in effect, the hip isn't a perfect spherical joint which moves around, and you get discontinuity, you get shock loading of the periphery, and you get the start of a degenerative process. With these variety of pathologies, it is possible to deal with them. So we go away from we're moving away now from a purely diagnostic to a therapeutic role of arthroscopy. So with the cam impingements, with these bump lesions on the femoral neck, they can be accessed in the peripheral compartment of the hip and actually reduced using a variety of instruments to take down the bump, to do a resection. And it's really quite taxing and demanding to build up these skills to know exactly how to do this. And again, there's controversy as to whether you can do this purely arthroscopically or whether you need to do open procedures. So, or indeed, sometimes a combination of both, a mini anterior approach to the hip to remove these bumps. With the pincer type pathologies, can be complex because you need to retain the labrum. So dealing with a pincer, you may actually have to detach the labrum, remove the extra bone around the acetabulum, and then reattach the label back onto the acetabular rim. But again, there is some controversy as to whether you need to always do the pincer element of a combined lesion, or whether it's just enough to do the anterior lesion with the cam impingement lesion. Very involved, very evolving dynamic area of debate and opinion. But in principle, if we're talking about hip impingement, the surgeon tries to reduce the impingement from dealing with a bump lesion, addressing any pathologies you can in the hip, sometimes resecting the labrum, sometimes repairing it, sometimes trying to address with microfracture, or if possible, maybe trying to glue back down some of the articular cartilage. It really depends on the process and the involvement of the acetabulum as to what the surgeon may or may not be to do. But in principle, our hip arthroscopy is keyhole surgery, looking at a variety of pathologies and dealing with them appropriately without resorting to open surgery. We're going to say something about how is our hip arthroscopy carried out. Well, I think the first thing to say, again, it's not a minor operation, hip arthroscopy. Just because it's a keyhole operation doesn't mean to say that it's not involved. And some hip arthroscopies can take a couple of hours, sometimes longer to do, but certainly the time of the procedure is variable, and some surgeons can do it in less than an hour. It really depends what's going on, whether it's about a therapeutic or just simply a diagnostic arthroscopy. But some of the essentials of the arthroscopy, that it needs to be done under distraction because the hip needs to be pulled slightly out of the hip joint. So it has to be done on a fracture table or a hip arthroscopy table, which means your foot will be in some sort of boot, and this can, through the foot, the leg can be distracted. A needle, the other important ingredient is fluoroscopy or X-ray control, so the surgeon can get visual spot checks of where instruments are and the distraction of the joint. So initially a needle is placed, normally from the hip arthroscopy done from the side, the patient on the side or the back, and there are different preferences and pros and cons. It's a matter of training and experience. Let's assume the patient is on the back, the patient is on the fracture table. A needle is placed just above the trochanter into the hip joint, which is verified on the X-ray, and going through into the joint, it reduces the vacuum and allows the hip to distract by about up to a centimetre or so, and that's essential to allow instrumentation of the hip. Fluid, once the various needles are used and these instruments are guided over these over the needle to get an increasing size, so that larger instruments of about up to 4 millimetres or so can be placed into the joint to allow a camera, and through different portals, initially assessed by needles and then ranged up to allow various other instruments through different portals. And again, surgeons have different views and arguments about which portals to use for different access to the hip. Instruments are put in, they could be hooks or suturing devices, or they could actually be shavers or cautery devices to remove bone to repair. And indeed, parts of the procedure, depending on what work's being done, some traction is taken off the leg to be able to move the hip joint around to get to the peripheral compartments. So there are different aspects from central compartment to peripheral compartment access. So those are the principles of the arthroscopy, and then afterwards these portals are really quite small and sometimes sutured, but not always.